So it's my honor to introduce Dr. Patricia A. Grady. She was appointed Director of the National Institute of Nursing Research April 3rd, 1995. And we're very pleased to have Dr. Grady here. I think it's very fitting as we celebrate our 25th anniversary along with NINR celebrating their 25th anniversary. She received her undergraduate degree in nursing from Georgetown University in Washington. She also pursued her graduate education at University of Maryland, receiving her master's degree there from the School of Nursing and a doctorate in physiology from the School of Medicine. Under her leadership, the Institute has more than doubled its budget and significantly increased the amount of research and training grants awarded. And I think we saw in our history notes yesterday the great increase, especially for us here in the South. She supported major initiatives such as pain management, end-of-life care, self-management of chronic disease, and caregiving research. As an internationally recognized researcher, her focus has primarily been in stroke, with an emphasis in arterial sclerosis and cerebral ischemia. She's a fellow in the American Heart Association, Stroke Council, and the Institute of Medicine. Before coming to NIH, Dr. Grady had several academic positions and serves concurrently now on the faculties of the University of Maryland School of Nursing and School of Nursing and School of Medicine. She's co-authored and authored many publications and papers on hypertension, cerebral vascular permeability, vascular stress, and cerebral edema. She lectures and speaks on a variety of topics: future directions in nursing research, developments in neurological sciences, and federal research opportunities. She's been recognized for several prestigious honors and awards for her leaderships and scientific accomplishments. She's a past recipient of the NIH Merit Award and has received the Public Health Service Superior Service Award for her exceptional leadership. Please welcome her and give her a warm welcome from the SNRS membership. Thank you. So you just do the down button or click.
Super. Good morning, everyone. It is a pleasure to be here, and I'm both thrilled and honored to be asked to do the keynote at your regional meeting. Actually, as I understand, the largest regional meeting of the four now. I am hearing some wonderful things about the program even before I got here, and it really is a pleasure to be here, particularly because we are both celebrating our 25th anniversary. And as someone last night at the dinner said, you know, it's a lot of work celebrating. You have no idea. And I thought, well, actually, I can resonate with that. So we have been engaged in a bit of a parallel set of steps to get to this place. And so it's very exciting to be here, and it's really wonderful to co-celebrate with you these remarkable anniversaries and landmarks. So I appreciate having the opportunity to talk to you today a bit about where nursing science has gotten us so far and where we expect that it will take us in the future. As I said, we haven't been engaging in some parallel steps along the way, and if you look at our shared missions, although we may state it a bit differently, we really have a great deal in common and have been moving along some parallel ideas and attempting to do some very similar things in concert, which really is as it should be and synergizes all of the efforts of nursing science. So what are some of our strategies so far? It's helpful in looking forward to be able to look back and see what got you to the place where you are and what are some of the things that you can build on. And as we move forward, we look to see what are some of the areas that we can build on, what are our strong foundational areas. And so what our strategies have been for building the science are the integration of biobehavioral approaches. We are among one of the only disciplines who is at the interface of biology and behavior and who can address both of these areas and in fact integrate them. Most other disciplines are have the expertise in behavior or in the biological sciences, but seldom are able to address both of these and in particular to integrate them. Also in developing and adopting innovative technologies. We know that technology is increasingly much more a driver of the science across the board, and in particular is emerging in the health sciences in ways that it hasn't before, and provides new challenges for us, but also new opportunities. And part of the opportunity and the challenge is incorporating these novel methodologies into the kind of care that we do provide now and that we will in the future. And as always for us, a major challenge is the preparation of the next generation of scientists. And that's one of the reasons it's particularly exciting to see so many students at this meeting and to see how very enthusiastic you are and how you're really on top of the science, and I suspect not missing much at the meeting. So the areas of research emphasis that have gotten us to this point and that are very strong drivers for us in the science are areas of prevention and also health promotion. This is something which historically has always been important to nursing, but now we have more tools and we're better able to implement this and to find new ways to engage in health promotion. Also, as I will speak a little bit later, it is becoming increasingly important. We have around us evidence of what we haven't done in our populations, and also what we now know that we can do. Improving quality of life and symptom management has also been a hallmark for us, and it really is part of what we are able to do as nurse scientists, and able to improve that now using a combination of biobehavioral approaches, which we have not before. Eliminating health disparities and setting directions for end-of-life research, all of which I will speak a little bit more in a moment. But, one of the things that really is a hallmark of the science that we do and how we do it is the fact that we are very collaborative. We have, in terms of the NIH campus alone, we collaborate with virtually every other institute or center on campus and have been for some period of time. We also, it's a wonderful way to collaborate from a scientific perspective and to synergize, but it also is, quite frankly, a spectacular way to leverage funding for us and increase our appropriation. So there are many benefits of that. We also have a very integrative and a system-based way of doing things, and that is really dictated because we deal with the human individual and we deal with people as opposed to other segments of people or from a disorders point of focusing on a disorders point of view. And we also have a translational focus in the sense that we start from the bedside, even if we come to the laboratory, whether it's clinical or basic, and we go back to the bedside. So our scientists are driven by the idea that what we do should matter to people and should improve people's lives. And that is a driver that is particularly important when you're looking at the societal health issues that we're dealing with as a country and as a nation and as a globe. So today I will talk about, it's always difficult to identify representational areas to discuss as advances. But what I will do this morning is to focus a bit on several areas which are deliberately disparate and which kind of cover the broad mandate of what we do as nurse scientists and what we have done. And I would also like to use examples that show very clearly how nursing science is making a difference in the lives of people and also being able to influence not only health care but also health policy, both of which are very important for making a difference. And as I said, these are not going to be exhaustive, but they will be exemplary. Now, the first of these is a bit unusual, and it is it is addressing a very important problem of chronic wounds. And as many of you know, this is an area which we have shown early leadership and still is an area of importance, but that is an area that we now have additional tools to be able to work in and to make improvement. I think it's an area that we went as far as we could for a while and are now making additional progress. So starting with the area of molecular genetics and wound treatment, I would draw attention, excuse me, probably need some water. I'm suffering from the bouncing from rooms to rooms in cold climates where we have forced air treatment. I also have been talking a lot since I got here. But thank you very much, Ann. So I would draw your attention to the work of a group of scientists formerly at Cornell in New York, now recently relocated to Miami, but in which the goal is to ultimately develop a very fast way to be able to identify areas of wound healing and success using a combination of clinical and genetic markers. And it reminds me a bit of some of the work of Norma Matheny in that it went from the bedside to the bench and back to the bedside. And so what Dr. Keynote is doing is attempting with her group to be able to rapidly identify areas of healthy tissue around wounds and to be able to identify those in a rapid way to facilitate wound healing. Now, as you all know, the clinical problem is a serious one, and not only is the wound itself a serious issue for healing, but it also carries with it a number of secondary issues and complications in the areas and even mortality in some cases. And it is whether it's the elderly or the young, whether it's from injury, whether it's our returning soldiers from the front. There are a number of areas now in which this is particularly important. And we are fortunate in that there are new molecular markers that are emerging that will help us to identify what is healthy tissue, what is potentially healable tissue, and what tissue is lost. And so rather than the wound healing and the preparation of debridement tends to use visual markers at this point in time. And the approaches that these researchers are studying would help us to be much more exact and would facilitate the healing, but also would help to prevent some of the loss of tissue unnecessarily. So you see, just as in a nutshell, you see before you what we know is an obvious wound bed of non-healing tissue. We see the non-healing edge around it, and also what doing this from a visual perspective, which is currently the state of the art, we can see where a true healing edge is, and we can see where the non-healing edge is. But the presumptive healing edge, which really does present a reasonable amount of potential tissue savings, is something that we cannot accurately identify from a visual perspective. And so Dr. Keynote and her team are using tissue markers to identify in patient populations what are the markers of this presumptive edge. And you can see you get a very different picture when you look from a genetic level, and a much more accurate picture. And so you can, pairing these up, be able to identify what are some of the areas which may be salvageable and would really save a great deal of additional morbidity and pain and time for healing for patients if this could be done. And it can be done now. It can be done now, but it takes several days at the point she is now and her team. And so the progress that they're making suggests that they will eventually be able to do this in real time. And so this is a work in progress. They've made remarkable progress so far. But the idea that you would actually be able to do this in real time, to be able to use swabs and something that looks like a pH marker, to be able to say, okay, this looks good or not. And then that can be done more easily in the home in an extended care facility. So the best way is prevention, but if we can't prevent, this would be a wonderful way to facilitate healing. Now moving to a very different area, I would bring your attention to the work of Dr. Pamela Mitchell and her colleagues at University of Washington in addressing the serious problem of post-stroke depression. And the question that they asked, which is an important question for us, is can health outcomes in patients suffering from post-stroke depression be improved through behavioral interventions? And we know that depression is a serious illness in general, but it is a frequent complication of stroke. And it is about 30% of patients, about a third of the patients, 33%, develop post-stroke depression following the stroke. And it is, as you might expect, associated with poor rehabilitation and poor recovery, as well as continued isolation from society, which is a serious problem with stroke in any event. Now, currently, antidepressants are the state of the art for treatment, and they have variable effectiveness, as we all know. And so, but there have been no long-term studies to this point on behavioral interventions. And so this group, very interestingly, said, we're going to take this on. And so they did a randomized controlled trial. Usual care arm was antidepressant, and the experimental arm was the use of a behavioral intervention called Living Well with Stroke, which is modeled on the Living Well with Alzheimer's dementia, which had been previously successful. So they used a tool that was validated in other areas, and also clinical observations and the usual scales for depression that we are familiar with. And the primary outcome for this group was at 12 months to look at the effects of depression. And the results were very interesting in that patients were improved at 12 months from the study, which is extremely important, but also the recidivism, the recurrence of depression in patients who had the behavioral intervention was better. The results were better in that arm. So not only was it immediately effective, but it appears to be effective in preventing the relapse that we often see in depression and stroke. So that was pretty exciting, and it is the first study that looks at a behavioral intervention and shows that it is successful in this patient population, a very large patient population, I might add. It is also a wonderful model for us for comparative effectiveness, because we don't have a large number of treatments in nursing that are considered state-of-the-art and accepted widely. And in comparative effectiveness studies, you need acceptable usual treatment to compare to. And so this is a nice model for us to use in other situations. So then moving on to a third area, and that is evidence-based medicine, which is evidence-based healthcare to us, and healthcare policy. And as you know, because we live in Washington, so we see this building on a regular basis. But you all, with the lively dialogues in healthcare and healthcare reform and around the country, are seeing a lot more of it yourselves, I know. And so it's a very exciting time. It's a time when you really have to pay attention to every minute of what's going on, because the dialogue changes so rapidly, and there's so many 180 shifts and even 360s these days. But having said that, being able to influence policy in a positive way for healthcare is a major accomplishment, and nursing science is beginning to do that. And so by now these slides are pretty familiar to you, so I'll move through them quickly. But looking at taking an example of the transitional care model, which actually takes on a very important health issue, that of the elderly in our society, of trying to improve the health care for the elderly, but in particular a number of populations within that group, but in particular patients with congestive heart failure, which is a very treatment-resistant group. And so this study in its various forms has shown that using the transitional care model of patients from discharge from hospital to the home, that we can provide an increased quality of care, as shown by the decreased number of rehospitalizations in the patients in the study, also by their own report of their feelings of improved care, that they feel that the quality of the care they're getting better. And also this particular series of studies has recently incorporated a cost-effectiveness piece. So it does show how much of a savings to the healthcare system that using this model does result in. And so that has been very instructive and has carried a very strong message about the effect of nursing science and nursing care and its impact on the health of our nation, and also the potential impact of having better health care on the cost of health care itself. So this particular study, the results of the study, the principal investigator, Mary Naylor, and her group went to the Hill and testified on this. And recall, this model has been, we've been talking recently about the time it takes to make important changes. And so recall that the roots of this model started with premature infants in the neonatal intensive care unit with Dottie Bruton, who is here actually at this meeting. And so it takes time to do these things. But Mary and her group testified on the Hill, and as a result of that, we had 2 bills in the Congress last session for reimbursement of the transitional care model. Recall when reimbursement, it actually takes a law to get reimbursement in most cases for CMS. And so we had this there were 2 bills in the Congress, and when the health care reform bill was passed, the tenets of this work were incorporated into it, including training of people to be able to implement the transitional care model. So not only did we have the workforce training, but we had the evaluation of it within the health care, and also, of course, treatment coverage, which is the big issue for us. And so that's very exciting and will have a major impact in the years to come. And we believe that this really is the first of many, because we have so many good ideas. But now that the ice has been broken, we feel that this is extremely promising and a harbinger of good things to come. Also, just as an aside, mentioning, we often talk about implementation, how do we translate things, and one of the keys for the success of this particular program is that it covers a broad audience, and really aspires to reach a broad audience, as do most of our studies. And so an advisory group was formed that would have representatives or consultations for this team of the variety of places and constituents that you see before you. And also another important message for us, the results and the news, as it were, from the study were posted on websites that would reach a large group of an audience that would be interested in this and that we would want to inform, as well as informing the public, which is a big part of what we need to do, and something that we continue to work on. There are a lot of us across the board and in the trenches, but getting our message out in a systematized way continues to be a challenge, and reaching audiences that are real community audiences, that are non-nursing audiences, who really are our patients and our constituents, continues to be a challenge that we really need to meet. And we're doing extremely well, but we need to just accelerate those efforts. So lastly, speaking about training and education, this continues to be a major challenge for us. I'm encouraged by, as I said, how many students we have in the audience, and you're not just students, you're future nurse science leaders and future leaders in the field, and I can tell that just from watching your behavior in the poster sessions and in the sessions. It's really exciting, and we have a strong commitment to that as a discipline and as an institute. We spend roughly twice the average % of budget of any other institute on campus, and the number 2, 3, and 4 down the line are not even close. So we are very committed to do this, and our commitment really encompasses developing this culture of science and mentorship, an early focus on career. The longer you have to do it, the more you can accomplish, and also to try to make sure that we retain the early budding scientists. It's a challenging field, but it's a very rewarding field, and it does take time. But a career is a lifetime, and so you have that time, and we just want to help you spend it wisely. And also recruitment of nursing faculty. we really need to worry about those of you in the faculty and considering how to help you mentor your own career while you're mentoring others as well, and to try to have the appropriate mechanisms and things to help you as well. So I mentioned that we spend, just a picture of what I just said, I mentioned that we do have more than twice the average, and we also are number 2 on campus. And as you see, the first National Institute of General Medical Sciences is called the Training Institute. So we are very proudly up there with them. Okay. Now, I know most of you are reasonably well aware of the mechanisms that we do have and the approaches that we have available for you. And I understand that many of you attended the session on Wednesday, and you're hearing a lot about it from all of our wonderful program staff that are here this session. So I won't go in great detail on these, and we also have more information available at our booth. Melissa Barrett will be there, and on our website. So, but just to remind you that we approach training as a whole career trajectory, and so we have mechanisms and approaches for you whatever stage of your career you are. So starting even as an undergraduate, we have the graduate partnership program, which I encourage you to check into. All of the schools that have T32s are immediately eligible for your students to participate, and those of you that don't, please, if you have an eligible student, please do contact us and we'll see what we can work out. We also have the Summer Genetics Institute each year, which has been very popular throughout its tenure trajectory, but it also is in the Part 2 format now. So we are able to accommodate more students, and it is more interdisciplinary. It is also shorter tenure on campus, and then moving out to your own institutions for the longer year of the period of time. So moving on from that, we have the NRSAs, institutional and also individual NSRAs, and we also have the potential for people to be supported on their mentors grants. Add to that the postdoc fellowships, both pre and postdoc, and also career development awards. We spell career with a K, and we have career development awards for every place in your career, whatever spot in your career you are, we have one for you, and we really encourage you to make best use of those. They are extremely flexible. We also, but I would bring your attention to one relatively new, and that is, well, two actually. We have the K-22, which enables you to come to the NIH to do a postdoc and then carry additional years of funding out to your tenure track position at a university. We also have the analog of that, the K99R00, which enables you to do a similar thing at another university extramurally. So you have the advantage of doing the postdoc and then you apply for the 5 years of funding. So you do your postdoc and then you carry the additional funding into your tenure track position so that you can segue into your research career in what we hope is a seamless way. One caveat here, that is, although it's a career development award, it is intended for postdocs really. So you want to make sure that you haven't signed on to your faculty position, because if you're a faculty member, then you would be ineligible. So just check those eligibilities and make sure you think ahead on that one. And then moving on, we have other career development awards, and of course a number of our awards, when you finish those, as you move throughout your career as senior researchers, and even we have the NRSA for senior fellows. So again, please check those in more detail, because we have exactly the right mechanism for you. It's just a matter of finding the right fit. So moving on, I did promise to talk a bit about the future, and of course none of us can predict. My crystal ball gets as cloudy as yours from time to time, but there are certain indicators that point us in a direction so that we can predict certain things. And so I will address briefly what some of those are this morning in the remaining time. And first, I think it is obvious to all of us in the field and people around who are not in the field, that there are a number of things that are converging. There are forces that are converging right now, and that are very favorable for us. So this is a fabulous time for nursing and nursing science, and we need to recognize that and take advantage of that. We have, I've mentioned, first and foremost, I've mentioned the Healthcare Reform Act and the implications that has for us, and I'll come back to it. But we also have the recent unveiling of the Institute of Medicine report, which was a combination effort of the Institute of Medicine and Robert Wood Johnson Foundation. And recall that the Institute of Medicine is a private nonprofit group whose mandate is to provide unbiased information for groups. And so they have just finished the study, which has a number of key messages to it, and these are before you. But the main message of that study is, if you are doing anything about healthcare in any part of the arena of healthcare, and you don't incorporate nurses, and nurses are not at the table, then you're not doing your job. And I think that is the strongest message, that anywhere you see health, you should see nurse. And so, yes. Yeah. And so we have to reinforce that. And I was speaking with Deborah Barkley this morning, who is a member of the PCORI, and that Patient-Centered Outcomes Research Institute, that's about nursing. And so we are really, there are a number of ways that we can enforce this message. So, but I think that it does, the report does, it addresses some of the issues we've been trying to deal with, and it addresses them in a very positive way and a very big picture way, so that it really does look at the entire healthcare arena and says, okay, how can we do better? And how we can do better is by putting nurses in places where they can practice to their full potential, that we need to facilitate their educational transition through the system, and we need to make it more seamless for them, so that they don't start a program for 2 years and then have to stop and then start over, et cetera. That we need to be thinking about that from an educational point of view. Also that nurses should be full partners in redesigning healthcare. And that was a struggle during the healthcare reform, and yet it did work. We had nurses very much engaged in all pieces of that, and everyone in the audience has been part of that in some way or other. And also, it became aware during the working of the report that there's a lot of data that we don't have, and so we need to be aware when we're doing this. And because we think about research, we do think about collecting data and evaluating, but we need to think about that across the board and get everybody involved in that recognition and everybody involved in doing this. So I think this report is going to be a major way to open doors, and if you have to kick the door open and stick the report in to keep it open as you're moving through, that's okay. So there is, and also there are a number of strategies that I think we can learn from, along with the actual substance of the report itself. And one of which is the strategy of incorporating and energizing across the states, across the country, to be able to implement these recommendations. And I think that is something that very clearly, when you look at our history book, you see how united nursing was across the country to be able to make the center happen and center/institute happen. And I think this is a strategy that they are reactivating in the report, and it's a strategy I think that we need to capitalize on across the board. So between the Institute of Nursing report, and also the tenets that have emerged in the healthcare reform, we have two enormous forces moving and synergizing in a way to promote nursing and push it forward. But we also have a number of transformative forces, and many of these are demographics, and if you look around, you can hear the increased drumbeats of moving forward in these areas that really all speak to how we can synergize and how we can capitalize and be much more successful, and also give us keys to where we should be focusing our efforts as we move forward. And many of these, if not all of these, are familiar with you, but it is important to look at them in the with a mirror of success for the future and where nursing science needs to be. And so one of these is the aging population. People are living longer, but they're living longer and developing some of the chronic illnesses that we haven't seen before, and in numbers we haven't seen before. It also it gives us. It tells us where we need to be in terms of what science we need to be able to deal with these issues. It also points us in the direction of the kinds of preventive measures that we need to take to be able to to be able to look at the future of our country and the future of our people and not develop these illnesses. And many of these, and although I'm speaking mostly about, because we're a federal agency, I'm speaking a little bit more about things in our country, these are also true across the globe. I've been visiting a number of countries over the last 5 years where they're speaking the same language we are in terms of many of the demographics. So we also have a growing racial and cultural diversity, and all the issues that point up what we need to know about healthcare and health issues, which we don't have now. The increasing reliance on technology throughout our society, it's everywhere. Those of you that have children and grandchildren know that it's hard getting a moment of real time anymore that you're not engaged in technology. Also, we have epidemic levels of obesity and type 2 diabetes. I will speak a little bit more about each of these. And a rising demand for a rigorously but broadly trained workforce to be able to deal with this rapidly changing and dynamic scene. So looking first at these, the aging population. Up until now we have been aware that the population was aging, and essentially what it is largely a tribute to the really good work and the successful efforts of the health scientists across the board, that people are now living longer. But with that, we have the concomitant increase of chronic illness, and also what we're approaching now is a dichotomy in our population, that if you look at the cross here, in 2020, there will be more people who are 65 and older than there will be 5 and below. And so what that says about the healthcare needs of the demands in the system and what we'll be dealing with is really pretty dramatic. So I think that the message for us is very clear. With regard to the growing racial and cultural diversity, we are a very multicultural society, and we address that, and we hail that as important. We believe in it, and yet we do have members of our society, particularly a number of cultures that are particularly preferentially affected by a number of disorders, and we do not have. We're getting answers, but we still don't have answers, and more to the point, we have not been able to narrow the gap in those disparities substantially. So that clearly is an area that we have a lot of work to do. Now, with regard to the technology, two big areas that are promising a way to the future, but are also impacting on our daily activities, include the area of genetics and genomics. We are unveiling additional approaches and strategies for being able to evaluate risk of people and to be able to personalize some of our interventions to individuals and groups of people. And so that will turn out to be an enormous boon for us to be able to reach the people more effectively that we are currently reaching more globally. And so I think, but what that means is that each of us needs to have a working knowledge of the language, the lingo, as one of my friends says, the language of genetics and genomics, to be able to engage in those conversations, to be able to be at the table, to be able to participate in the decisions that are so important. And so we really, and we're moving in that direction. We are quite impressed with the graduates of the Summer Genetics Institute and the various programs that you all are developing across the country, and how successful they are in getting that information translated into their science and into their practices. But it really, so it is an area of great activity, and for us really, we are the group who have been doing risk assessment for centuries now. And so this will be yet another tool in our armamentarium of risk assessment. So that because we're now beyond the if you have a gene you're going to get the disease mode, that we understand that most of the disorders and most of the difficulties that people experience, whether it's cognitive, physiological, et cetera, that these are complex disorders. And so it isn't a simple matter of it's all genetic. If carrying a gene will give you a predisposition, but also you have other modifiable risk factors. So this is going to be extremely useful for us as the future moves out. The other one of these areas that we are that is emerging, that nursing has always been a pioneer in, is informatics technology. That many of the things that handling all this data, the new technologies for grouping and clustering studies for clinical work, et cetera, that there are a number of ways that will be particularly important. So we are watching the emergence of information technology in our practices and in our science. Okay. With regard to epidemic levels of obesity and type 2 diabetes, this is something that is not new news, but the severity of it is pretty dramatic. That you look at nearly 2/3 of our population of adults are overweight and obese. And this was in 1999, the last Surgeon General's report. As we look at 2010 and 2020, we see that very little has changed. In fact, it's gotten a little bit worse across the board. So that we have a large number of adults overweight in our population, and also children. We literally have, according to the latest American Heart Association studies, numbers which are more recent than the Surgeon General's, 1 out of every 3 children in the United States is either obese or overweight. And so we're seeing now, for the first time, we are seeing type 2 diabetes, which was formerly called adult onset diabetes. We are seeing in children, young children and teenagers. And so this is clearly, does fit the bill for the official definitions, even if we hadn't decided unofficially that this was epidemic, that it literally is epidemic. And so what do we do about this? The Secretary has focused a great deal of her attention on this and has declared a war on obesity. The First Lady of the United States, Michelle Obama, has also named this as a particular area of focus for her, and in children in particular. And so we have a high-profile focus on this, but it's still up to us and people like us to develop the strategies which will help to intervene in this really important area, and it will be with us for some time now. Okay, Now, lastly, developing a rigorously broadly trained workforce. Now, we do, I think we could not be accused of not developing a rigorously trained workforce in nursing and nursing science, because it is really, it is a very challenging curriculum, and each time we try to add something new, it's really a struggle for, if you add something new, like, what do you eliminate? Because you really cannot put many more things into it. But having said that, it is really important that we train our young so that they are well-versed in knowing what they know, but also understand that they're part of a broad system that is rapidly changing, so that they can be prepared to adapt to change and prepared to take on new issues, and to understand that actually for all of us these days, someone from the yesterday from the podium said, it was Martha Hill said, if you're not ready to change, you're in trouble, because basically the world is changing around us. And I think that is a message that's important for all of us, no matter what we do. But in particular in the area of healthcare, it will mean that whatever you're trained to do in your program is unlikely to be what you're doing in large majority 10 or 15 years down the road. But the principles that you learn and the approaches that you learn and your philosophy of learning and studying, that will stay with you. So that it is really, so the challenge for us is to give people the basic of what they need to be able to adapt later is kind of an interesting way to design a curriculum, but it is very clearly what we need to be doing. Okay. Now, I also, many of you know, and I think it's been mentioned earlier in the meeting, that our strategic plan is being refined for the next 5 years, so that we are building our strategic plan to help guide us for the next 5 years. It is the rough draft, the first rough draft. Well, it's not the first rough draft, but it's the latest rough draft is on the website, and it is available for comments. We have an open comment season on it, and that is until March 19th. So you still have some more time to look it over, pull it up on the website, and to make comments. And we do invite comments. We understand that you may just pull it up and look at it and say, okay, fine, I have no whatever. But we do want to alert you so that you can pull it up, so that you can look, and so you do have an opportunity to comment. And because I know you'll do that, I don't want to spend too much time on it, but I will just briefly go over the tenets of it, so that I can familiarize you with it, so that when you go to look, you'll already have a head start. And so essentially, when we look forward, what we look at is really, our mission is to advance the science of health, and to really, our final goal is to improve the lives of the American people, and also the people, our partners around the globe. And so our goal is that. And so the other things that we have listed are steps along the way. And in order to do that, we continue to feel that advancing, health promotion and disease prevention is very important. Improving quality of life, that is what our goal is, and a major way we do that is symptom management and also prevention of the symptoms of chronic illness. So whether that is preventing the chronic illness or managing the symptoms when it occurs, we feel that those are important tenets. Also improving end-of-life and palliative care. This is something that we've taken the leadership at NIH, and the importance of this is obvious, but the importance of this is growing, and the dialogue around this is increasing across the country and the world. So we do feel that will continue to be important. We also are focusing on enhancing innovation in nursing research. We know that there are areas in which, and I think the wound healing was an area that is one of those, where you make great progress and then you plateau a bit, and then you have to wait for the next innovation to be able to ramp it up and to make that area much more dynamic. And so we know that we recognize that there are areas that is likely the issue, and so we want to make sure that we shine a light on those and that we do something about it. And also developing the next generation of nurse scientists, which will continue to be important. There simply are not enough. And part of the dissemination and the communication and getting the word out is that we have a research workforce that is outstanding, but they're also, from time to time, a bit overworked. There are big issues out there, and so we need all the help we can get. So just moving through each of these points that I've mentioned and giving you some bullet points that kind of summarize what the strategic plan says, so that we can give you a head start. And so looking at health promotion and disease prevention, we're looking at behavioral systems and behavioral patterns. How do you change behavior? Because it's easy to tell people what they should be doing, but we know that simply providing information has not been very successful, and we've all proved that to each other interdisciplinarily. And so we're also looking at models for getting people started early, and models that will provide a lifelong healthy system for them. We're looking at ways to translate what we learn, to translate those into usage, into practice, into policy, and also to be able to incorporate interdisciplinary partnerships in health promotion. Again, this is a big job, and we want to make sure everybody's working with us on it. Advancing quality of life, again, we know much more now of the biology of symptoms, and we can incorporate biomarkers in with self-report. We have new measurement approaches to be able to study this, and we want to make certain we incorporate those. And also looking at clinical effectiveness and outcomes research. We fund some of that, but now we're better able to look at outcomes. And again, we want to be patient-oriented, but we want to be able to show that what we're doing is effective, and to be able to show that in a way that is unequivocal. End-of-life and palliative care research. We know in this area, we know more about what we don't know than what stacked up about what we do know. And again, we've made some marvelous steps forward, but it is still an important area and a difficult area to research. It is also an area in which we need to look across populations. We need to create new communication strategies. It's also an area in which health disparities are not only evident, but that the cultural competencies in this area are even more important than some other areas. If something is important to you when you're feeling fine, it becomes even more important when you're looking at a limited lifespan or an attenuated quality of life. Investing in innovation, we do have some wonderful opportunities now. We are in many ways we are the interface between technology and the patient, and so there are a number of opportunities for us to be able to be the people who can figure out how some of these new advances will be very effective and will make a difference in people's lives. We have, we've started in this. We have a couple of studies, one of which is looking at communicating health messages about HIV/AIDS prevention through PDAs and using a soap opera motif that the teenagers seem to be just enamored with. And so, and interestingly enough, that has received a lot of press and a lot of media attention because it turns out we were the only ones doing something like this at NIH. In fact, somebody said, aren't you a little worried that this might, a reporter called and said, aren't you a little worried that this might sound frivolous? I mean, I said, no. I said, we're going where the patients are. So we should be doing that. We also, and I think the innovative use of technology and other innovations are a way also for us to be able to partner better with our global relatives and our global partners across, in areas that we have difficulty reaching and that we can't always travel to, and they can't always travel to us. So we think about it for rural and underserved populations, but I think it's a wonderful way to be able to better partner with the rest of the globe. And then investing in neuroscientists. I've talked a lot about that today, but again, I think if we can determine additional ways to get trans-institutional, interprofessional kinds of things going, and we depend on working with you, our partners in the university settings, to be able to help us identify some creative ways to do that. Because everybody, we always get teased about being siloed at NIH. I'm going, wait a minute, have you been to an academic campus lately? Some of those are a little complicated to traverse as well. So we really need to do that in partnership. We also want to get people early. We want to recruit people early, and we want to think about models that will help facilitate them to continue their career and not do quite as much stopping and starting, so that we can get these careers started early and have them seamless throughout. So in closing today, I would just like to say that we, as you, are celebrating 25 years, and we have a few more events that are upcoming. We are doing the grantsmanship workshops at all of the regionals, and we hope that as many of you as wanted to get to the one on Wednesday were able to be there. I've heard a lot of feedback from you so far, so it sounds like it went well, and that many of you did attend. So we're happy, we're excited about that, and we're still waiting for feedback. We'll get all the evaluations. We're also having a joint conference with the Clinical Center on May 2011, so if you happen to be there for any other reason, or those of you in the area, please feel welcome, please come. We're sponsoring Science in the Cinema, which is movies that have a health message, and we combine them with a leading scientist in the area coming to talk about it and translate some of the messages to the general public. And also welcome all of you to attend our scientific symposium in the fall, which is October 13th, and it's the week that everything else is happening with the Academy. So we're all pretty well interlaced, and we hope it'll be seamless, and we'll look forward to seeing all of you there. One related to that, one last announcement as I'm closing, is that we do have the deadline for posters is March 15th, and we encourage all of you to submit posters, and we welcome posters of work in progress, work that's been accomplished. If you've presented it somewhere else or you're presenting at the Academy, don't worry. We really want to highlight the work that you have done, and we want your posters there. So please do submit, and make sure that you write that deadline down, March 15th. So you still have a little time. So please, we are really looking forward to that. It'll be a wonderful session, and it's so exciting to see all of you in the same room. We also have a lot of visitors who love to see what you're doing. So again, and again, congratulations to you. Congratulations to all of us. This is a very exciting time. We are forming the future, and we're driving forward on it, and we want to work with all of you. We invite all of you to work with us. We are there to work with you. We really want to make the world a better place, and sitting in this room are a group of people who can make a major steps forward in that event. So thank you all very much, and just keep doing what you're doing.
Thank you so much. Thank you.